This is Chapter 2, Subjective Data, the Interview, and Health History. So for the Chapter 2 objectives, we're going to look at different styles of interviewing and also the different types of communication. And then we'll dive into the complete health history and all the pieces of the health history. Your subjective data includes symptoms, feelings, perceptions, preferences, ideas, beliefs, or values from your patient or anyone really that gives you these type of feelings. You can count those as subjective. Any personal information that's obtained during the interview that is elicited by the client, maybe the client says, I feel hungry, or I have pain in this particular area. That is subjective data. When we're interviewing our patients, we do a lot of these interviews when we're getting their health history. We always want to start by building a rapport, a trusting relationship with your patient. And we'll give you suggestions of how to do this, but a big thing is that we want to show the patient that we care about what their thoughts and feelings are. We talk to them when they speak, we listen to the answers, and provide respect and dignity during the interview. We're going to gather data on lots of their physiological issues, any psychological things that are happening, spiritual status. We're going to discuss all those things. So the phases of the interview are introductory, working, summary, and then closing. In the introductory phase, we're going to look at their chart, look at their health record, maybe some notes that the physician has provided or a previous nurse. When we are talking to the patient, we're going to explain to them what the purpose is of the interview. A lot of times you will get more compliance from your patient if you tell them why we are having this discussion. It's not just to get information for no good reason. We are trying to collect subjective data so we can assist in making their plan of care. We always want to make sure that we maintain their confidentiality. This is a HIPAA code and Health Information Protection Act. And so we don't share information. We don't discuss your clients out in public areas. If there's patients or family in the room, we make sure that it's okay to have these discussions in front of them. And that's very important to provide respect and dignity for your patient. We always want to make sure the patient is comfortable and has privacy. We provide privacy by closing doors or securing the area. We make sure the patient's comfortable having the discussion. You can imagine if the patient's not comfortable or we're not providing their privacy, they may not share as much information during this interview because they don't feel like they have that trusting relationship. So very important to have that trust verbally and non-verbally. And a lot of times when you're having a discussion with someone, you can tell if somebody really cares about what you're saying by maybe their stance or their eye contact, maybe the tone of the voice and how they respond. So as we're talking about these interviewing, think about how you feel when people are addressing you in different ways. If you walk up to the counter at a fast food restaurant and the person never makes eye contact with you, has a very curt tone, and does not smile, how does that make you feel? In the working phase of this interview, we're going to collect biographical data. What is the age of the patient, the birthday, their gender, all those kind of things. We will also collect what their present health concern, what brings them into the hospital or the acute care setting. It's important for you to identify what the patient feels like the reason for seeking care is. It helps you establish their understanding of what's happening in this situation. We want to collect their past health history, their past hospitalizations, diagnosis, any family history that has been present in about the last 3 generations. As you know, with genealogy, probably in your past, that there's a lot of diagnosis, hypertension, diabetes, cancer, things like that, that if there's a family history, some of those diagnoses are genetic. So it's important to acknowledge those, especially heart disease, strokes, things like that. The review of body systems are actually the systems in the body: respiratory, skin, cardiac, neurological. So we will ask them questions about those specific body systems. And if there's any past history, we would definitely emphasize in that area and try to find out information about those things to help put the patient's story together. All those, even though they might be seeking health care for one problem, we need to acknowledge their past history because some of those things will affect their plan of care. Their lifestyle and health practices are very important. Do they exercise? What is their diet like? Do they smoke? Do they drink? A lot of those things, as you probably well know, can negatively impact or positively impact their care and some of their diagnosis. So we need to know what those things are. What is their developmental level? What is their education? These things also are going to impact how you care for this patient. So we are going to listen as we gather this data. Use our critical thinking skills to interpret some of this questioning. A lot of times when you're talking to a patient, how they answer is going to help direct you in your interviewing. Maybe if the patient said that, yes, they do smoke. Well, we need to know more information about that, right? How often do you smoke? How much do you smoke? What do you smoke? All those questions are very important as we validate a possible concern in that lifestyle practice. So we're going to collaborate with the client to identify their problems and goals. Maybe we can identify a SMART goal, specific, measured, and timely, to for their care while they're in the hospital. So in summary and closing, we always want to end gracefully. We want to summarize the information that we have. We are working with the patient to validate some of those things. And this is a good way that you can make sure that your interpretation is correct and valid, because it is what the patient says it is. And so we want to make sure that we're all on the same page. Very, very important. We want to make sure that the patient is on board with what the established problems and what the goals for the patient will be. When you are working together with the patient to identify this information and set up this information, the patient feels included. This builds that trusting relationship that you're working together to help move this patient forward in recovery and resolve the problem. You will get much better results when you have the patient's participation. So it's very important that everybody's on the same page. You're discussing plans to resolve this problem, that the patient's included, and if they would like, that the family is included as a support system. We always ask about concerns. Any further questions? Is there anything else that you'd like to add that we have not discussed? Very, very important. The patient should feel like they have every opportunity to ask questions about their care, to ask questions about what some of the our interpretations of the subjective findings are. We want to clarify any of those things so we can reduce any misunderstanding, but always finish your interview with giving them an opportunity to add something. As most of us in a discussion, a lot of times we don't think of something until later after this discussion has already passed. So it's always important. And sometimes the little things that the patients don't think is very important ends up being very, very significant. So we always ask those questions. Like we talked about earlier, nonverbal communication, as you know, when we were talking about um, going up to the counter at the fast food restaurant, and we talked about the actions of that employee and how that made you feel. I, having experienced that in the past, I think that that would make me feel like the person really doesn't care um, whether I'm ordering there or not, or whether I'm a customer there or not, or maybe that employee is upset about something or mad about something. So a lot of that nonverbal behavior, even though it has nothing to do with me, impacts how I feel. So this nonverbal communication is very important. And nurses, as the most trusted profession, we want to appear the most professional. We want our uniforms being clean, our ID being clearly shown. You want your hair, nails, everything to be the most professional possible. We want to appear warm and friendly, very neutral. We want to ask questions and then give the patient time to respond. It's very important because that impacts how you're listening. It's active listening is very important. Hearing a patient's response versus actually listening and comprehending what they're saying are very different things. Your posture is very important. If you are slumped over or you are turned away from the patient, how does that make them feel? Do they feel like you're really listening? When you're facing the patient and you're making eye contact and you're really listening, you're not speaking, you take the posture of somebody who cares and who is actually listening to what the patient's saying. And your attitude should always be non-judgmental, accepting. You may not agree with what the patient is saying. You may not understand initially what the patient is saying, but you should not be bringing your own bias to that conversation. You listen with an open mind. We definitely want you to avoid uh, insufficient eye contact, excessive eye contact. We give the patients their space. Um, what's appropriate, 2 to 3 feet. We want to be at the bedside, but maybe not hovering over the patient. That can be uncomfortable. Um, you can sit at the bedside in a chair if that eye level is more comfortable for the patient. A lot of times we'll stand at the bedside and talk to your patient, um, but we don't want any of that posture to make them feel inferior or less than. We want to build that trusting relationship. In these pictures here, examples of this body language and nonverbal um, communication, what are some of the things that you might see in the example? We have different pictures. Um, so look at these and see. Sometimes we have behavior and have gestures and nonverbal communication that you may not even realize that what you're doing. So, for example, in this picture in the top with the girl with the white shirt, what do you think from looking at this nurse? What impression are you getting from them? How about the picture where the nurse is kneeling next to her patient in the wheelchair? How about these ladies that are down at the bottom? What kind of impressions are you getting from their nonverbal behavior? So there's a picture in the bottom right, and it just gives an example of things. Now, I would say many times you may have some automatic responses when you are talking to your patient or if things happen in the room. And these type of things can make an impact on your patient. So um, sometimes you want to practice having this nurse face where you can remain neutral but pleasant, and avoid this over gesturing that might impact your patient. Verbal communication, as we will talk throughout this program, is asking open-ended questions. Tell me about how that made you feel, or can you explain what happened here? Um, so we want to avoid the yes, no questions. We want to have them elaborate and tell us more information. Sometimes if the patient is struggling with defining things like pain, we might give them a laundry list of things. Does that pain feel dull or aching or sharp? If somebody doesn't understand the pain level from 0 to 10, we may say your pain level of 10 is the worst pain you've ever felt, um, that kind of helps them define, clarifying information. And then you need to allow the patient to reflect on what you're saying, and not rushing them through that, but give them some examples of how what you're saying is can be validated. So you may have heard this before, but when we speak to patients, we expect that they absorb a very small amount of what we're actually saying, and they get a lot more response just from the meaning and the tone and the body gestures of what we're trying to communicate. So this is really important. So if 7% are the words that you're saying to this patient, we may need to repeat this question, clarify, make sure that the patient understands what we are saying. Maybe that might be interesting to you to know that 55% of your communication with your patient is that body language, is that nonverbal. So we need to use both the verbal and nonverbal communication to help convey whatever message you're trying to share with your patient. We want to encourage them to elaborate sometimes. So we may say, okay, go on. I understand. Uh, encouraging them to continue. A lot of times, your patients do not are not able to verbalize all their information because people don't give them that time and space to do that. So it's very important, as much as you can, that you let them talk and you let them share, because you will find so much out from your patients. It's not just about collecting lab work and the um, your your physical assessment. You get a lot of information. 50% of your information is from your conversation with your patient. So it's very, very important. You find out where they're at psychologically and their understanding, which is extremely important in your patient care. Um, we don't want to lead your patient in one direction or the other. That's why they've given them that space to answer these questions is so, so important. And then they are able to ask you questions. But when you're providing information, you can answer the questions that you know. And if you're not sure the answer, then you can tell them, I need to find that out for you, and I will get back with you and provide you that information. You only give answers for things that you 100% know are true. So again, verbal communication to avoid professional jargon. You don't want to give them these big words that they have no idea what that means. Interrupting them, obviously this is very inappropriate. You want to give them the time and space to answer. Any false reassurance, like it's going to be okay, you're going to be fine. That is false reassurance. We definitely don't want to do that. Unwanted advice, you can understand what that might be, that you're telling them what medications that they should take or what procedures they should be doing. The only thing that you can really share is your own experience. Telling them what they should do is that's not appropriate. So with your older adults, a lot of times these patients, they could be frail or they could be healthy. I know many people, you see older adults these days, they're more active than ever. We always are going to watch them and make sure they're hearing you correctly when you're speaking to them. Sometimes they may tilt in if they have hearing better in one ear versus the other. But you're always going to face them and you're going to observe and see how they're responding. If you are speaking to them or asking them a question and they're not able to answer you or respond to the commands, you might assess and make sure that they're hearing you appropriately. Just as with any client, the trust is essential. That when you tell them that something, that it is true. So when you tell them you're going to do something, that you do it. Very, very important. We want to make sure they don't feel ignored, that you are listening, not just hearing what they're saying. And you're speaking clearly and showing respect for their dignity and for their privacy is extremely important for any age of patient. We do that for everyone. So some of the cultural considerations may be that some patients, regardless of the culture, may be reluctant to share personal information. Sometimes this is very uncomfortable, especially if you're asking uncomfortable questions. So providing privacy, all those kind of things are essential. You may have some variation with language, verbal and nonverbal behaviors. Sometimes you may need an interpreter when you're having discussions with patients who speak a different language. And there may be some things that are impacted by translation, but you're always going to try to give the respect that you would anyone who deserves the best care. There's a lot of variation, I think, sometimes people for disease and illness perception, and we'll talk about that culturally and spiritually as we go throughout. But those things are important to try to accept, even if they're not your culture. It's important to your patient. So staying as unbiased as possible is very important. So if your patient is older, maybe they, you know, or younger, they may, uh, their orientations, their family roles, this may impact their care as well. So you always ask the patient and make sure that you are acknowledging anything that they need. And you find that out by asking them a lot of times. So again, working with an interpreter, there's a lot of different ways that facilities are doing that. Some have iPads where it's a tele interpreter. Some places have phones where you call, but you need to know that your patient deserves to understand their care just as much as anyone. If there's a language barrier, that is something that we deal with as a healthcare provider. We never have them sign consents that they have not been able to read. That is not appropriate. So be patient. It takes time. You're going to have to work with a healthcare provider, not just family, and um, they need to be a trained interpreter. A while back, we used to just have whoever was available interpret, but we found that there's a lot of words that are difficult to translate. Um, and so we have healthcare providers are asked to do to get a certified interpreter. So this is very important, and you will be asked to apply this in this situation as you move forward, and you will do this as a nurse. We do this in the facility, like I said, with an iPad, and it's visual, and uh, so you might have either one of those experiences, but it does happen. There are times when you might have interactions with difficult clients. Maybe they're anxious or depressed or maybe even manipulative, or sometimes some clients are angry. So the general rule of thumb is you want to provide simple, organized info in a structured format. You want your communication to be very, very easy to understand when somebody's in an emotional state, right? You're going to explain what your role is and the purpose of your conversation, assessments, and be sure you're asking simple and concise questions. You want to facilitate any personal space if that's making somebody uncomfortable. Sometimes your position in the room can cause anxiety. So making sure you're giving the patient the attention, facing them, and not crowding them too close or anything like that is important. You're not going to rush. You want to remain neutral in your demeanor and your nonverbal behavior. I would decrease any external stimuli so you can facilitate a smooth communication between you, especially when there's an emotional state. That can be make things a little bit easier if the TV's not going, the family's not talking at the same time. That can be overwhelming for your patient. And if needed, because your safety is paramount in any situation, or if your patient is just very depressive and you're not sure how to handle it, be sure that you always get help from the charge nurse, the other nurses if you need some help. If you have somebody who's angry and you are uncomfortable, you can have somebody go in the room with you. Not in a threatening way, but just in a safety type situation. So those are options when you're dealing with difficult clients. When we discuss sensitive issues with your clients, you want to be aware of your own thoughts and feelings. We talked earlier about bias. A lot of patients have different views about dying, spirituality, sexuality than maybe what you do and what you've experienced in your past. So you need to acknowledge, well, how do I feel about that? Can I be open-minded and unbiased when I'm talking to my patient? Because sometimes verbally, non-verbally, your opinions seep into the conversation. Um, think about when you're talking to an acquaintance and they have or um, somebody out in the world, a stranger, and they ask your opinion about something socially, politically. Do do you give your opinion strongly? Do you listen? When you're talking to your patients, a lot of these things are very sensitive. So um, and when you're asking questions, you're asking in an unbiased and open-minded way as well. Being non-judgmental is very important. If your patient feels like you're judging their most sensitive issues, very rarely will they be honest when they're talking to you. If your patient feels like that you would judge them about their lifestyle practices, things like that, they may not be honest with you when they're talking to you about some things because it's very sensitive. People don't it doesn't feel good to be judged. We always want to allow time for patients to share their feelings if they need about sensitive issues. Maybe they have felt some bias in their own choices that they've made, and we need to give them space to discuss that if they feel like they need to. It can be very uncomfortable if somebody has very different opinions or practices or those kind of things from yourself. And we need to practice having a nurse face where we are objective, that we are not rolling our eyes or making frowns or doing things like that when we're listening to patients. And sometimes this can be even happening when you're not aware. So make yourself aware that these sensitive topics that are deeply personal, um, you need to have that appearance of being open-minded, non-judgmental. And if you feel like in a patient's particular situation that you're really not comfortable, then you might reach out to someone else and ask for assistance in this, because the whole goal is to provide the best care for the patient. Um, and we want to do that for them. So when you're talking about the complete health history, we need to identify relevant nursing problems. We have this discussion before we start doing our objective exam. And when you're listening to the answers of the questions, you might think, oh, okay, when I am doing my objective assessment, I'm going to focus my assessment in this area that they said is of concern. So you will be collecting that information for your patient and for yourself while you're doing the health history and review of systems. So we usually do this complete health history when we are admitting the patient maybe for the first time, or it's the first time we've met the patient. We want to get a baseline of information, and then we'll continue with ongoing assessments after that. So again, here are all the pieces in the health history. Here is what biographical data is. We had a discussion about this, but we want to make sure that you know all the different pieces of the health history. And so review this for yourself, specifically what these things are, um, so that way you know all the pieces. And you will see this in your electronic health record. And all these things are very important to take into account for biographical data. So your present health concern, we talked about this earlier. What is your major health problem or concern at this time? Is very important. Is in the patient's own words. It's what they understand the health problem to be. We use this as a basis for the symptom analysis. When we have a symptom, then we start asking questions about that symptom. So this is cold spot. This is the mnemonic that we use for the symptom analysis. Say if your patient has pain, we might say, what does this pain feel like? Well, it's dull or aching. We might ask, when did the pain start? Well, it started this morning. Where is the pain? A lot of times where the pain is helps us identify what it might be related to. Is it an organ? Is it something else? So how long does it last? Is it constant, intermittent? Very important. What is severity? Scale of 0 to 10. What makes the pain better or worse? Maybe when I take Tylenol, that makes the pain better. When I'm running up and down the street, that makes the pain worse. Associated factors might include maybe I'm nauseated with the pain. How it affects the client, how does it affect you? I'm not able to do the activities that I enjoy. That's can be how it affects the patient. So your personal health history, here some examples of personal health history, pieces in that, medications, all those kind of things, any hospitalizations or surgeries. If somebody's had chronic illnesses, diabetes, etc., it's important to know how long, what the dates of those are. You want to know how long somebody has been dealing with that chronic illness, because a lot of these illnesses are progressive. So be sure that you acknowledge that as well. Um, Hospitalizations or surgeries, you would also want to know when those are. If somebody had an abdominal surgery yesterday, that would be a big difference than somebody had an abdominal surgery 20 years ago. The healing would be different, right? So it's very important we have that information. Same thing for accidents or injuries. Um, Emotional or mental problems, history of depression, if somebody's being treated, if um, um, when those things have happened, especially suicidal ideation or suicidal attempts. Very important if somebody's been hospitalized for that. We have a big insurgence of um, suicidal uh, issues that are very prevalent out in the hospital, and we address those very, very seriously. It's very underreported, so we have those discussions, and that can be a very sensitive issue, but be sure that you include that when you're asking about your patient's past health history. Family history, that makes sense. Genetic conditions, we talked about that earlier. So, this is only subjective information. You'll provide objective assessments for each system, and we'll have primary assessments that are for every single patient, regardless of their present health concern. We're always going to listen to the patient's lungs, always going to listen to their heart, always going to listen to their abdomen, and always going to assess their neurological status. So, but in this review of systems of the health history, this is only subjective information. This is only their history. Have they ever had issues of skin, any rashes, any warmth or erythema to the patient, any bruising? So we ask these questions, but it's all subjective, right? We're going to document any denial of signs and symptoms. Maybe your patients had never had issues prior in one of those systems. Then we would note that as well, that denies any issues. So review of body systems, we talked about. Here's all the list of the systems. And so we are going to go through each of these systems throughout the semester. We're going to talk about diagnosis for each one and um, help identify what some of the appropriate questions might be for each system. So if your patient has a present health concern with the skin, then we would review those systems. And we'll talk about that each module as we deal with those. But this is the review of systems that you'll very frequently see in a history and physical in your electronic health record. So we finish the health history with lifestyle and health practices. We talked about this earlier, and here's a list of examples of those practices. Very important that we address all these things. They impact the care of the patient. As many people know, nutrition and weight management impacts all kinds of diagnosis and disease processes. So we need to have an idea of how that is impacting the patient. Is there anything that we need to address in their plan of care? Activity levels, sleep, rest, all these things are very important and are included in that health history. So we conclude with this, and thank you very much. Here's a brief summary of Chapter 2 content. What is the most important nonverbal or verbal communication, and why? What would you avoid with your communication style? Give an example of open-ended, closed-ended questions, and maybe the laundry list in your communication. Are there considerations you might have if you were needing to work with an interpreter? And what does the cold spell stand for example? What does that mnemonic mean? What are the all the pieces, and what are some examples of each one of those letters? What are the pieces of the health history? Do you know all the different categories, and can you give an example of each category? These are part of your summary for Chapter 2. Thank you.